Yeah, perhaps we can ask the group at the end about or you can put a survey out as to what people want. I mean, the way I'm thinking it is possibly some sort of case-based discussion group as sort of peer review thing. That's probably better for your CPD anyway, isn't it, rather than
Yeah,
didactic talks.
yeah.
Um,
I'll
okay,
put that
so
all out. Yeah.
shall I carry on?
Yes, please.
Yeah, okay. So with the thread of OCT interpretation, again, the primary focus of these talks is really talking about the OCTs rather than the disease or the management pathways and such. We're talking about the spectrum of changes you see in various retinal vascular diseases. Um, okay, so it would be great if someone just shouts out, it can be completely anonymous as to what that appearance is. Someone, please. Total silence.
Still silence, yes. See what you
Is it
see.
papilledema?
Okay, so we've got a blurred disc margin, so that's something. How about the sort of general appearance of the blood vessels? So try and work out where the arteries and veins are. So firstly, it's difficult to say. Again, this is the difficulty with an optomap. So maybe that's something worth talking about. That the false colors tend to make it very difficult to interpret because the orientation, dilation, person's
There is some,
pigmentation is all so difficult.
there
Well,
is
the
some
key,
comments in the
yeah,
chat. Artery
cool.
occlusion, narrow vessels.
Yeah, exactly. Yeah. So there's certainly attenuation of the, well, it's difficult to say where the arterioles are and which the venules are, but that is not normal for an arteriole. But that whole back, and then with the optomap, you get that greenish hue often when something is slightly elevated. So that is probably the remnant of a cherry red spot, but everything's very distorted on an optos. So, and there's box scarring or very slow flow in that. So there's a very sort of characteristic appearance on it. The whole purpose of showing this is, oh, what do we do? Wrong slide. Okay, so with that, of course, it's an emergency referral because if you pick patients up within the first couple of hours, if they walk in, I mean, in practice, this rarely happens, but thrombolysis is an option. I think I've seen it work once in 20 years, so it's not a great option, but it's something which we consider. But if by the time someone comes to either their GP or optometrist and then goes to the eye casualty and then gets seen and then referred to the stroke physicians who then assess whether thrombolysis is a possibility, the window of opportunity is often missed. And it's fibrinoplatelet plaques which respond, and actually it's not the bulk of things we see at the back of the eye don't really respond. So anyway, going back to the OCT, the characteristic is an acute ischemic infarct. It's an acute ischemic insult. So you get remember there's lots of different types of edema. You can get intracellular or intercellular. Most of the diseases where things leak, we see vacuoles, which is intracellular, between cells. This is the cells are dying, so they swell up. So it's a very different type of engorgement. That retina is very definitely swollen. There's a very hyper-reflective appearance from the inner retina and a loss of detail more posteriorly. Remember, the photoreceptors get their nutrition from the choroid, so they still stay alive. So this is another appearance. Does anyone want to comment what this looks like? Has anyone said anything on
Not
in the
yet.
chat? No.
No.
Okay, so I mean, it's the same sort of appearance, where there's pallor at the back of the eye, but there's the distinct edge here, which you can see. And in the middle of that, there's a couple of blood vessels, which are cilioretinal arteries. So
Yeah.
occasionally, well, 20% of the general population or the humans will have a cilioretinal circulation, which is separate from the central artery, originates from the short posterior cillaries. Um, So you can get ciliary retinal sparing. So again, we'll look at the oh, I don't know what's going on here. The OCT. So on the infrared reflectance, you can see where there's this superficial opacification of the retina, which is due to cell death, essentially, which is why there's this whitish appearance. But the bit that's supplied by the ciliary retinal artery is still spared, so it looks relatively normal. So depending on what the extent of the ciliary-retinal circulation is, people can either maintain actually amazingly good acuity, but of course you lose a big chunk of your visual field. But even a little bit of acuity and a bit of central vision is really helpful. Um, so it's always worth noting because not every retinal artery occlusion has catastrophic visual loss. So, about 20, as you said, about 20% of patients will have. So these are really medical emergencies. And the late consequence, this causes cell death, essentially. Remember, hypoxic injury and infarct are two different things. Hypoxia is just a slow deprivation of oxygen, and infarction is an abrupt termination of oxygenation. So the neural retina dies when there's a blockage. It can survive 20 minutes or so, approximately, and after 20 minutes to 4 hours, you get a really rapid decline in survivability. So, of course,
Could you bring
when
a tissue, love? Thank you.
sorry, what was that? Oh, was that microphone's off? Yeah.
Yeah, I apologize. Yeah, that was someone.
Yeah. No, that's okay. Yeah. So there is that other thing about when patients present acutely about massaging the eye if there's an embolus to try and dislodge it. I suppose it's worth trying and getting to rebreathe out of a paper bag, plastic bag, whatever bag you've got, because you're rebreathing your own carbon dioxide, which has a vasodilatory effect. But realistically, we don't really see that has an effect. So going back to the OCT, which is what we're really talking about. So if you can see my cursor here, that is the inner retina up to the plexiform where there's a superficial, intermediate, and deep capillary plexus. In an artery occlusion, it all gets blocked. So of course, you've got edema and cell death in that zone. And then the late consequence within a matter of weeks is it just completely withers away. So even though the photoreceptors stay intact, there's no bipolar layer or ganglion cell layer to relay that information back into the brain. So again, take a few seconds, just have a quick look at that. Can anyone spot what the abnormality is here? There's a few things going on. Anyone going to offer something?
There's nothing in the chat at the moment.
No? Okay, a few things. There's a little nevus there. It's an elderly
Oh,
patient.
RP is one person has said.
Yeah, so this is reticular degeneration, and we're talking about vascular disease. Yeah, you do get vascular changes in RP, you get vascular attenuation, but this is peripheral reticular degeneration. It's an aging change of the peripheral retina. The thing I want you to spot was that, which is a little white blob just at the bifurcation of blood vessels. So that's a retinal embolus, almost certainly a calcific embolus. So we do differentiate different types of emboli. Calcific and cholesterol look slightly different, and they have slightly different origins. So calcific tend to be larger, wedge in at a bifurcation. Cholesterol, and it has an origin in either um, calcified heart valves or or the aortic arch. Cholesterol emboli more likely comes from atheroma, and that's more typically in carotid stenosis. And fibrinal platelet is if you get an ulcerated atheromatous plaque and then a clot forms and then which dislodges and breaks into the circulation. So that is a branch retinal artery occlusion. In this case,
Can
it's a
I
very,
ask a question?
yeah.
Sometimes you can see these sort of emboli and it almost looks like it's sitting on top of the blood vessel. Is that just because of the reflectivity?
Yeah, it's because of the retina is transparent, so we don't, and it's very thin. So our power of resolution is not great. And remember, when we're looking at the blood vessels, what we're seeing is the column of blood within the blood vessel wall is actually transparent. unless it's become fibrosed for some reason. So it does always look odd. There's almost a sort of optical illusion where it looks like it's because normally we don't see things. The plane of reference, everything we see, the retina is transparent. It looks like it's floating because the plane of reference is the retinal pigment epithelium. So of course it's going to be in front of the retinal pigment epithelium. That's what you're really seeing in a transparent retina. So it looks like it's floating. It's really just an optical illusion. It is still in the retina and it's still in the vessel wall. It doesn't become dislodged or anything. And when we scan these things, you can occasionally find an embolus. Very, very difficult to find, but they're typically within the vessel wall. But it's just that it gives you a different plane of reference. So you can judge depth in retina, particularly if you've got a big clump, you can see where the pigment epithelium is below it. And it's the same with pigment migration in RP, say. So that pigment migration, it gets liberated from the retinal pigment epithelium, migrates into Muller's cells. So you see pigment in a different plane to what you're used to seeing. So it's probably just illusory.
Okay, thank you.
So that's a chronic retinal artery occlusion, and we know that because when we do that scan, that retina has completely thinned out. The embolus is just distal and outside the scan, but very occasionally you can find the vessel. Well, that's a vein which we're seeing there, and there's obviously a PVD there. But the key with any of these acute, particularly arterial diseases, and it's also this case with a venous occlusion, in the long term, the inner retina just withers away, which is why the vision loss is really quite profound, and the visual field loss is quite profound. So on that, the visual field in this case will very much match the OCT on-FAS map. We can see thinning from the cool colors, which respects the horizontal meridian. So, you know, the vascular anatomy always respects the horizontal. Neurological things respect the vertical. Sometimes it can respect, it can look like a quadrant, but of course, if it's a neurological quadrantanopia, it'll be bilateral and homonymous, whereas retinal vascular disease tends to be clean and neat, restricted to one eye alone. Okay, so anyone want to hazard a guess as to what's going on here? Let's see what's going on in the chat.
Silence on the chat at the moment.
Okay,
Oh,
maybe I'll have...
MA, vein occlusion, DR.
Yeah, so the key is to look at the veins. So the veins look very dilated and tortuous, and there's a lot of hemorrhage going on. So in terms of diabetic retinopathy, most diabetic retinopathy starts off as a posterior pole disease, and you get a mix of changes. I mean, there's very few microaneurysms as such. The predominant change is blots, deep blots, some with a white core. So this was a young patient who we ended up referring for hematological investigation, because if it looks like a Roth spot, then you've got to be certain it's not some sort of blood dyscrasia, some sort of problem with the blood screen. So things like leukemic or severe anemic retinopathy can sometimes look like this, but you won't get venous engorgement and tortuosity. So this patient had good vision, but was just aware that the vision had become compromised in some sort of way. And something's in my way here. So we saw the patient just a couple of weeks later. So most retinal vein occlusions that present are non-ischemic. So there's probably a lot that go on out in the community that would never ever end up coming to us, but population surveys have told us that something like 85% of vein occlusions are non-ischemic. So it is a minority which end up becoming, but a third end up decompensating. So overall, there's a sort of rule of thirds. 1/3 of vein occlusions will just spontaneously clear up by themselves. 1/3 will show some signs of tortuosity and persisting hemorrhage and low-grade compromise, and 1/3 will decompensate with macular edema or vision loss. So this patient we just saw a couple of weeks later, a lot of the hemorrhage had surprisingly cleared, some of the venous tortuosity had settled. And then just 6 weeks later, actually, most of the problem had almost completely gone. And her thrombophilia screen was negative. So we never came to a cause, but she was symptomatic. So if you have a look at this OCT, this was at presentation. There was a little bit of engorgement of the disc. The disc doesn't usually rise like that. But if you look, there's no frank macular edema. There's no elevation of the foveola, the foveal profile, remembering that sort of 1, 2, 3, 4 approach, which we discussed months ago. The dip is continuous. The lines of the nerve fiber layer is intact. The plexiform layer is intact. But if we look at the nucleated layers, there are little pacifications. So this is this finding, which is very, very common in vein occlusions, PAM. It's back pressure on the capillary bed causes very localized infarct. There is some sort of watershed in the inner capillary, in the intermediate capillary plexus. So that appearance is PAM, but it does settle down. But you can see there's a gentle sort of undulation. So there's a consequent thinning because it's an ischemic insult or an infarction of the bipolar layer. So often there's very little to see. You know, that scan, most people will pass off as being essentially normal. But if you look at the plexiform layers here, they're pretty smooth and continuous. But here they're much more irregular and corrugated. And whereas the inner nuclear layer here is pretty continuous and straight, it's very up, down, and then more peripherally it becomes straight. So this patient remains symptomatic with a certain patchiness to vision, and that's because of the late consequence of PAM. So often the scan doesn't show any hemorrhage, doesn't show any edema, but the subtle changes, which will explain the patchiness to the vision that these patients complain about, is really relating to the loss of intercommunication between the photoreceptors and the deeper layers. So the national guidance always used to be these patients, particularly if they're young, this lady was in her 30s, get referred for hematological investigations to make sure there's no inherited thrombophilia. So protein S, protein C, antithrombin 3, all these various deficiencies in clotting profile. But about 5 years ago, the British Hematology Society said, actually, we don't want to see vein occlusions anymore because the pickup rate is so low. And the theory and hypothesis is that if these patients have got a true thrombophilia, they're going to get DVTs, PEs, and the rest of it, irrespective of the vein occlusion. So the current college guidance, Royal College of Ophthalmologists guidance is detailed history, blood pressure, glucose, full blood count, and ESR. And that'll pick up most changes, which will predispose. So this was the lady I've just shown. You can see that on the OCT scan, sorry, something's in my way on here. Yeah, so just from July last year, which is when she presented, there was an engorgement. That looks like a normal scan. And then she'd thinned out a little bit. So there was another little clue explaining her patchiness. But even that scan, probably for her, was a bit more engorged than normal because there is always a back pressure in a vein occlusion, and the macular edema or the diffuse retinal engorgement can be quite subtle. So here's another case. I won't ask, it's along the same thread. It's also a vein occlusion, but there is a difference between the hemorrhage. You see, the hemorrhages in this patient are just look at the color of them, and then look at the color of the hemorrhages in this patient. So this patient's vision was 624, but these are much darker hemorrhages. So deep, dark plot hemorrhages are much more indicative of ischemia. Such a variable beast, retinal vein occlusion. So his vision was 624, and that was his OCT. So it was the same sort of thing. The vision was down. There was no macular edema, or the most subtle of subtle macular edema. There was a little tiny cyst there, but his foveal contour was okay. But you can argue that the foveal contour was a little bit deeper than usual, and that's due to this diffuse engorgement that you see. Now, on the infrared reflectors, you can often see these dark shadows, and there wasn't any hemorrhage of the central macula. So it's not hemorrhage which is causing that shadow. It's the same PAM-like appearance. The retina should look like that. You've got this increased hyperreflectivity going on, and that's a sign that the retina is sort of in trouble. But for ischemia, we can't do anything. There's no injection therapy doesn't work. It only works for macular edema, frank gross thickening with intraretinal cystic changes in subretinal fluid. It doesn't work for PAM, or which is essentially an infarct. So this patient came back. If you look at the dates, it was February 25, 3rd of February 25, and then March 28th. He came back. So we said there was that rule of thirds, that 1/3 of patients do decompensate. And you can see how that looks terrible. It looks odd because the venous engorgement has all disappeared. And it's really quite unusual. This is more to knock home the story about the extent of hemorrhage. So that's an indicator. It's very sort of arbitrary. If you look at the textbooks, it'll say non-ischemic and ischemic retinal vein occlusion, and that sort of arbitrary vision worse than 660 on a fluorescein angiogram at the center, more than 10 Tescaris of non-perfusion. But the key clinical changes, deep dark hemorrhages and columnar spots. So, you can still have good vision despite all that. But this patient, you can see, has got really large confluent blots, but those blood vessels have just completely disappeared, and the central retina just looks completely white. So he went from that PAM type appearance to this, which is pretty much just dead retina. Now, when someone's actually, I put that wrong. He wasn't 624. He was 624 at presentation. He was perception of light at this level. So our perception of light, the vision never comes back at that sort of level. So we end up doing a prophylactic panorama photocoagulation because his risk of rubeosis is huge with that degree of ischemia. So that just adds insult to injury. So we tend to any very ischemic vein occlusions, we do tend to do prophylactic PRPs because treating rubeosis is just an absolute nightmare. Once that vision, if the cornea goes cloudy, if the pressure rises to a certain point, you can never get sufficient laser on to keep the eye comfortable, and then rubeosis is painful. It's the worst thing that can happen. So again, it's the same thing. This is severe vein occlusion, but the end result is really it just kills off inner retina. Now, if there's macular edema, it responds much better, but still in the long term, the inner retina tends to thin out a little bit. So this is a variation. Again, just to knock home another rule, it's still another vein occlusion. And we've talked about the ciliary retinal artery. So last time there was preservation of vision due to a ciliary retinal artery, which still perfuses retina. But the ciliary retinal artery is a low pressure system. So arising in the short posterior ciliaries. So there's a vein occlusion here. It's a very mild vein occlusion, but it creates enough back pressure on the capillary bed. And we said that the ciliary retinal artery is a low pressure system, so it can't perfuse. So this patient's ended up with a ciliary retinal artery occlusion. So remember those first patients we showed where there was a cherry red spot and slightly opacified retina. So in this case, even though the vein occlusion is really quite mild, there's a back pressure and it's blocked the ciliary retinal artery. So the rule is even if it's a mild vein occlusion, if the vision is disproportionately poor, always look for a ciliary retinal artery because more often than not, if there's a ciliary retinal artery present, it'll get occluded as a back pressure. They don't respond to treatment. You can't treat that. So again, a very, very similar appearance. But actually, this isn't an arterial occlusion. It's a venous occlusion, which is caused back pressure, resulting in a secondary arterial. And the same story, it becomes bright and white, and then it eventually thins out, and you lose the foveal contour. So you lose the foveal depression because the surrounding tissues just disappeared. And remembering the photoreceptor gets supplied by the choroid, so that remains intact, but it's got nowhere to relay onto. And then other variants are hemiretinal vein occlusions. which are relatively uncommon because that's just depends on the variation on the retinal vascular supply. And again, it will just respect the horizontal meridian. So in this case, all the edema in a branch vein occlusion, it's always a wedge going up to a branching point. We're going to talk about branch vein occlusions, but it's always at the point of where an artery crosses over a vein, invariably related to arteriosclerosis. There's a common adventitia. So if the edema goes up to the disc, it's either a CRVO or a variant known as a hemiretinal vein occlusion, which we, for treatment purposes, treat exactly the same way. So the fluorescein angiogram shows it very well that the inferior veins and vessels are all still normal. Everything is very engorged with loss of the normal retinal vascular architecture superiorly. So in a classic vein occlusion, the problem tends to relate to intraretinal hemorrhage. Blood is toxic to nerve tissue because when blood cells, erythrocytes, break down, they liberate iron, and iron is just supremely toxic. Iron foreign bodies in the eye destroy eyes within a matter of days, and really heavy bleed causes the same sort of problem. It's toxic to the inner retina, or toxic to the retina full stop. But this patient's vision is compromised due to macular edema. So we can see there's a loss of the foveal depression. There's a bit of a general engorgement, which we can see from the corrugation, because if everything starts expanding, the first thing is you see a corrugation before it starts spreading out. So vein occlusion patients we will treat with anti-VEGF agents ASAP. So these patients really, if the vision is down, they just need to be referred to ICAS immediately, really, if you don't have confidence in your local referral pathway, because the best visual outcomes undoubtedly are by treating within the first few days, really. We know the guidance says you can treat up to 2 weeks later, but we see patients who really decompensate and have a poor outcome. Okay, so we've already given some clues as to what this is. Anyone want to shout out, or do I need to just give up on getting audience participation?
Give them one last chance, and then
Well,
perhaps we
then I'll
carry
give up.
on. Yeah.
Okay. No, yeah, we've given the opportunity for everyone to be silent now. Okay, so if we look at everywhere else outside the disc, the blood vessels are okay-ish. I'm saying ish because there are changes in these vessels. But the key is all this hemorrhage stops abruptly. And it stops abruptly at the point where that artery there crosses that vein there. So where the artery and vein cross, which happens at numerous points, there, there's a common adventitial sheath. So this is because this hardening of the arteries. So most vein occlusions can be ascribed to either hypertension or dyslipidemia, high cholesterol. That's a majority of them. Diabetes is a small risk. Smoking is a small risk. Glaucoma is a really small risk, which are the sort of classic 5 textbook risk factors. So it's everything downstream of that. Obviously, there's no venous return, so the capillary bed pressure rises, and then it just becomes overwhelmed, and it leaks and bleeds, and it becomes edematous downstream. So again, the rule is deep dark hemorrhage is bad news because that suggests ischemia and toxicity to the retina. But just look elsewhere. So what do we see? So there is some arteriovenous clot. You can just see that vein gets nipped in, not to any dramatic degree. But the other thing is, the general rule is the artery to vein ratio. And again, look at this vein subtly. It just get this artery, it just narrows there. So there's focal arterial attenuation. It's a little bit narrow there. And then the fellow eye of this patient, um, there's the vein, there's the artery. Now that artery really varies in its caliber. Remembering the artery should taper gradually. It shouldn't narrow and then open up again with narrowing there. So it's a really subtle sign, but it's very typical of stage 1 hypertensive retinopathy. So stage 1 is where you've got diffuse arterial attenuation. So the normal artery to vein ratio is, so again, look at this, that artery and that vein next to it physiologically, it should be 1 to 1.2. So there should be a sort of 20% increase in the size of a vein in relation to its sister artery. But that's double the size. So it's a subtle sign that there's issues with blood pressure. So stage 1 hypertensive retinopathy is diffuse arteriolar attenuation. Stage 2 is where there's focal arterial attenuation. For me, that artery there is wider than it looks there, and it's wide there, so it narrows there. It's a very subtle sign. So, but always look out, and then look out for arteriovenous crossing changes. So there's a difference between true hypertensive changes, which is muscular spasm of the vessels, and arteriosclerotic changes, which is chronic changes. So that's where you start seeing silver wiring, copper wiring, and all that textbook stuff, which in actual fact, we rarely see these days. They were written in the 40s and 50s, where good blood pressure control was not evident. So people had uncontrolled blood pressure. Most people tend to have good blood pressure control because these things are picked up by GP screening these days. So anyway, this patient had terrible classic macular edema, and this is the sort of miracle of so the other eye looks like that, looks great, looks perfect. In actual fact, hypertension doesn't generally cause changes at stage 1 or stage 2. And then this was after injection number 1. So we can see how it just improved from that to that. Then injection number 3 and 4, and then the most recent scan. But you can see what's happened to the retina. The inner retina, despite successful, the initial response looked okay, the inner retina is intact, but chronically these patients do end up decompensating. And this is probably little bits of exudates in the retina. And exudate's always harmful as well. It eventually gets cleared away, but the mechanism the body uses is macrophages, lysozymes. It dissolves not just the exudate, but it dissolves nerve tissue as well. So it's a little bit toxic. So even though superficially that looks okay, there's a loss of the normal banded architecture of the retina, which is why this patient says, "Oh, my vision is terrible," even though her acuity is 7.5. She sees brilliantly on acuity chart because the foveola, it's only the foveola which gives you 6.6 vision. You can have 6.6 vision with foveal involvement. So it depends on what's been preserved. So she's got a sort of dense quadrantic defect, and the patient was working as a medical profession, but lost a binocular field, so found her job very, very difficult. Okay, so another case here, very, very subtle. Again, so there is venous engorgement, but there's no, here's the other side for comparison. So you can just see how the blood vessels are a little tortuous. They get tortuous because the veins expand. It's like the back of your hand. If you squash your wrist, the veins dilate. The veins are very fluctuant and complex. There's no valves in the blood vessels, so they're much more prone to dilatation, but they're pegged down in certain places. So they're rigidly pegged down. So everything between then becomes much more tortuous because the vein expands in response to that intraluminal pressure. So the other eye is much more straight and normal path of the blood vessels. So we know something's awry. So the patient hasn't really got macular edema, but it's that PAM story which we see over and over again. It's very much an OCT diagnosis. We didn't know this thing existed until it was pointed out about 13, 14 years ago as our scanners got better. The lower resolution scanners, or if you look at the picture in color, you just won't see the changes there. But it's pattern recognition, which is the case for most OCTs, that again, you get this subtle change. So again, the vein occlusion itself is negligible. So, this historically was called an incipient vein occlusion, which I'm not entirely sure is a thing. It's probably just a very mild non-ischemic vein occlusion, but obviously the pressure is high enough to cause back pressure on the intermediate capillary plexus to kill off a bit of the nerve tissue. So the other eye for comparison, again, what a normal scan looks like is a line should look straight. There should be the nucleated layers, the outer nuclear layer, inner nucleated and ganglion cell layer are all relatively dark in comparison. And when we look at the pathology, obviously it jumps out. There's a change. Okay, so as when we weren't getting many volunteers for cases, Have a look here. So subtle changes, really. There's a couple of cotton wool spots, so something is going on. Now it's much, much more obvious that that arteriole has really disappeared into nothing. So that's arteriolar attenuation. Have we got some AV crossing changes? Possibly. And again, the relative uh, dimensions of the vein in comparison to the artery. So we know something's going on in the blood vessel supply. So if we look at the OCT scan, it's going through an old cotton wool spot, so we get a localized elevation. You can see the cotton wool spot not so clearly on the optos. It's just that little thing there. So remember, cotton wool spots happen in crops and in different stages of evolution. A fresh cotton wool spot is white and fluffy. An old vintage change is like that, and then they eventually disappear, leaving a little bit of superficial. So we've talked about thinning in the intermediate plexus. These are changes in the nerve fiber layer or the superficial capillary plexus. And the other eye has got much more fluffy, fresh, new changes. And if we go through an OCT scan, it's much more obvious, the dilatation. So again, going into this eye, by definition, if someone has got cotton wool spots, that's stage 3 hypertensive retinopathy. So stage 1 was just diffuse attenuation of the arteriole. Stage 2 was focal change. And again, look here, look at that arteriole, just sort of disappeared away. Then unless you point it out, it's sort of very easy to miss, but it's very obvious now that you see, you know, there should be a blood vessel, which is very similar in size. These are just the veins draining. The arteriole's almost invisible. And then it becomes more obvious here. So that would be called focal arterial attenuation. But when someone's got cotton wool spots, we'll label that by definition as stage 3 hypertensive retinopathy. And that's the cross section. So going on, just through the staging of hypertensive retinopathy, there's hemorrhages, flame-shaped or splinter hemorrhages. They run in the nerve fiber layer, so they're superficial hemorrhages. Blot hemorrhages are deeper, which is why they have a different shape. There's other changes going on in the vasculature. There's some sheathing. It's very difficult to say whether that's the artery or the vein. There's a bit of exudate there. So, and then blot hemorrhages in the periphery. So that constellation, and there's some question as to what that disc margin is doing. So there's a lot of stuff going on. So that by definition would be stage 3, where there's exudate, hemorrhage, cotton wool spots. Same on the other eye, there's a little bit of exudate going on. To try and explain what that exudate is coming from, if it's coming from the nerve, then by definition that will be papilledema, a leaky nerve head. This looks much more localized as a cercinate, so there could be some sort of localized abnormality. But peripherally, there's changes, hemorrhages. Again, the arterioles are very attenuated. Look at the caliber of the artery there in comparison to the vein, and that one as well, really, really thinned out. So I think you get the picture. Arterioles go into spasm with blood pressure, which is out of control. There's a beautiful example of arteriovenous crossing change, and that deflection you see just because the vein and artery have that common sheath. And then stage 4, or hypersensitive retinopathy stage 4, is where there's disc swelling, so it's very definite loss or blurring of the disc margin there. Probably chronic. There's no hemorrhages as such. It's not completely fluffy and opacified. And of course, those exudates track in Henle's layer, which radiates out. So that radiation goes in towards the central macula, and it can end up with a macular star appearance if really the whole of it. So that on the OCT scan, we can see exudates. The rest of the retina looks okay. There's no edema. When it's very chronic or very profound, it does track straight into, and you get a serous elevation of the retina as well, often intraretinal cystic change, subretinal fluid when it's very marked, but you can see that disc is very, very heaped up. So it's a chronic change in this case, rather than being acute. In acute, you see a bit more fluid and a few more fresh hemorrhages. Okay, have a little look, see what you think on that. So again, it's the history which is important for most cases of retinal vascular disease because they all sort of look the same. There's not much that can happen. Blood vessels either get occluded or not. Blood vessels, when they're damaged, they leak. Blood vessels, when they acutely get occluded, get cotton wool spots. So the signs are pretty much the same. There's dot hemorrhages, blot hemorrhages, exudate. But again, it's pattern recognition. So what can this be? We didn't show examples of macular vein occlusions, but a macular vein occlusion, a macular branch vein occlusion would respect the horizontal meridian. So there's exudate suggesting chronicity. There's little microaneurysms, which are both, so the horizontal meridian's there. There's microaneurysms below, microaneurysm or hemorrhage above as well. So there's quite a wide area of leak. If there's exudate there, we know the change has been there at least 4 months or so. And there's the same patient side, we can recognize the vasculature. It's not at exactly the same time point because the exudate looks slightly different, but it's very, very swollen. So again, the key thing in this is it's above and below, so that would make it very unlikely. It's slightly eccentric. It's very localized. So this is the angiogram of that patient. So this is juxtafoveal telangiectasia. Now, if it was a vein occlusion, it would look very similar, but it wouldn't be above and below. If it was a macular branch vein occlusion. A branch retinal, a proper full blood branch retinal vein occlusion, which show a very similar pattern, but it would respect the territory of the draining vessel. So there's masking from the exudate, which is what all these dark splodges are. So the fovea is still intact. And in juxtafoveal telangiectasia type 1, there's a sort of incorrect grading historically, type 1 and type 2. They're completely different diseases. So we think that type 1 juxtafoveal telangiectasia is a developmental anomaly where the blood vessels never formed in the first place. It's on the continuum of Coates disease, whereas in type 2 juxtafoveal telangiectasia, which sounds like it should be the same thing, but a different subform, that's a Muller cell disease. And it doesn't really have a vasculopathy. You can get secondary neovascularization. You can get some slightly anomalous vessels within, but they look completely different to this. So this, to all intents and purposes, will look like diabetic retinopathy, but diabetic retinopathy tends to be more widespread. You typically do get it in the temporal area first, but you would almost always see evidence of change at the posterior pole. So small hemorrhages, microaneurysms, potentially cotton wool spots. Now, with juxtafoveal telangiectasia, we do recognize it's on this continuum of Coates disease. So it's just a question of severity. When it's very localized to the fovea or macula, we tend to call it juxtafoveal telangiectasia, but angiographically, the findings are identical to Coates disease. There's capillary non-perfusion. As you can see, we often see peripheral changes in juxtafoveal telangiectasia. And there'll be sort of leakage as well because there's incompetent blood vessels. But these blood vessels have been poor since birth. We don't know what the inciting event. It's more likely to be blood pressure. The patient has blood pressure elevations, which then just tip the balance. But more often than not, the change has been there, well, inevitably been there. And we see these patients presenting at any age from 20s, 30s, often later in life. I saw someone last week who was in his 70s when we decided that we had juxtafoveal telangiectasia rather than anything else. And they respond very well. So we've done a cycle of treatment. He came to us from elsewhere, and anti-VEGF rarely works in this. So in that case, in his case, we didn't. I tend to use depending on how extensive the macular edema is, and if it's got features of chronicity, I often give an Ozurdex implant, which dries things out a little bit, and then it enhances the uptake of laser treatment. So we did 2 or 3 sessions of laser 6, 7 years ago on this guy, brought him under control, and he's not had any supplementary treatment for 5 years. So essentially, you can almost say you can stabilize this very effective. You never cure it because you can see that there's still drill, so disorganization of the retinal inner layers. You can see the retinal architecture is intact here, but it becomes very disruptive. And that disruption is a biomarker for ischemia or anomalous ischemia. So you get loss of capillary bed perfusion, which we saw on the angiogram. So that laser treatment will also do some controlled harm. But remember, untreated disease, untreated persisting exudate and edema causes widespread atrophy. With treatment, we'll keep this patient stable, and he's maintaining excellent vision. He recovered vision, and he's about 6'9" or so, and kept 6'9". So this is another case. In a way, it looks very similar to the last one with some peripheral change and some maculus change, but this was a 14-year-old. So very, very profound exudation. And the telltale sign, which we say is you get this cluster of, well, it's incompetent blood vessels. We think that Coates disease spectrum, this is Coates disease, is a failure of ocular vasculogenesis. There's a number of diseases which fail to cause normal blood vessels to grow. Remember, angiogenesis is pathological new vessel growth. Vasculogenesis is normal blood vessel growth. So that is orchestrated by a series of proteins and genes. And we know multiple genes have been implicated in various disorders of abnormal blood vessel development. And Coates disease is one of them. And the gene that's potentially implicated in Coates is the same as in FEVR, has certain changes in terms of Norrie's disease as well, and PHPV, all these conditions that give severe ocular malformations, which are incredibly rare. But anyway, this child, when he was first seen at 14, obviously went to his optometrist for a checkup, was horrified to find this change, which no one had really detected. And then the periphery's got lots of little light bulb aneurysms with essentially exudates, fibrosis. This is all exudate, looks slightly different. Fibrosis is as a result of chronic change or chronic subretinal hemorrhage. And then there's very incompetent blood vessels. And the macula of this 14-year-old looked like that. So, you can never recover from that, particularly when you've got all this subretinal accumulation. But we have treated him. I just did a few when he was 14, so I felt he was old enough to cope with laser. He was a big strapping lad, so he coped with a contact lens. And we did laser. So, all his macula had exudates. And here we are 7 years later, and actually, he's preserved all his nasal retina. So we've preserved visual field, but that's all subretinal fibrosis. But the whole scar shrunk in. And here's the change you see on the angiogram. So that's the central macular scar. Actually, a lot of the macula is intact. So his vision loss will just be restricted to where the scarring is. Will keep largely his binocular vision. And again, it's the same appearance that you get this filigree pattern, you get non-perfusion, you get these little light bulbs. So when we laser, we just target these. And what happens through life is different crops will keep appearing. And we see these patients every 6 months. When I see microaneurysms, I just zap them. And in the long term, they stay stable. And more often than not, by the time they hit their 20s, we end up on average lasering people every 18 months, every 2 years, very, very, very infrequently. And we keep the
Have we lost audio?
Oh, can you hear me?
Now we can, yes.
Yeah.
Yes.
Okay. I've got a message saying my internet connection's unstable. Did you hear the rest of it on the last?
No, we missed the end of the sentence.
On the last one.
Yeah,
Yeah.
we heard all
Yeah.
of this bit.
Okay.
Yeah.
So this is something we see a lot of in Southeast London. Peripheral neovascularization. If you look at the scans, there's lots of shut down blood vessels. So even where there's this neovascular complex, the real key clinical feature is there's blood vessels or ghost vessels, just peripheral. And these are very, very spontaneously fibrosed. There's no evidence of any laser treatment. Normally, when we see neovascularization, we'll fire up the laser immediately. And looking at the other eye, there's sort of fibrovascular contracture, neovascular complexes, little hemorrhage. Remember, we said most hemorrhage tends to, when it's chronic, ends up deoxygenating and going dark. This is very bright red hemorrhage. So this is sickle cell retinopathy, proliferative sickle retinopathy. There is a staging system and classification system. We don't need to go into that. But the reason for mentioning sickle in this context, apart from the what looks horrible, we tend not to do anything because they're auto-infarcts. This it doesn't really benefit from laser. This just fibrosis by itself. The biggest risk is vitreous hemorrhages, mostly which clear by themselves, but occasionally if there's a big one, we'll have to reluctantly go in and do a vitrectomy. But patients are prone because that peripheral retina, because it's had a chronic progressive hypoxic damage, it thins out the inner retina, as we've shown on the previous examples. When you lose inner retina, you've only got photoreceptors left. These patients get retinal detachment from contracture. So these fibrovascular complexes contract, it pulls, and you can see how it scrunches up the retina, and then eventually the retina breaks and causes a secondary regmatogenous detachment. They're very difficult to treat. So even though they're regmatogenous, they're not regmatogenous in the way you get a typical regmatogenous age-related change. You can't just zap around the hole and it's sorted. So they are a nightmare for the VR surgeons because the vitrectomy is very difficult. These neovascular complexes leak protein into the vitreous, and the vitreous changes. It's not just 99% water and protein. The VR surgeons will say the retina is very difficult. The vitreous is very difficult to cut. They have to segment. It's very easy to induce iatrogenic or surgeon-induced breaks. So sickle is a nightmare. We haven't really solved what to do with sickle patients. But the key thing in sickle is they often, a reasonable proportion of, so it's SC patients, which are systemically generally quite well, who have peripheral change. The macular change is seen more in SS patients who have proper sickle cell disease and crises and more sort of life-threatening problems. So there's something about the temporal retina where the vessels are a bit more vulnerable and you get areas of localized thinning. And again, it seems to be episodes of PAM which cause this. So this is a progressive thing which slowly develops with temporal thinning. And you get the old acute patient we see in our sickle screening where they have these little episodes and then it thins out. You can just see how that appearance looks very similar to the PAM cases. Apart from there's a bit more loss of superficial inner retina as well. So that's a right eye. The other thing of note is there's an epiretinal membrane. And we've already said there's a chronic transidation. So it's more likely. So something like 5 to 10% of young sickle patients have an epiretinal membrane, whereas normally we'd see without a PVD, whereas normally we'd see that as an age-related finding with PVD. So again, you can see how if the retinal vasculature is compromised, the retinal architecture, then the neuronal architecture follows. Many diseases are a mix of neurovascular diseases. You know, there's a theory that diabetic retinopathy is a neurovascular disease as well. And people are suggesting that actually the nerve damage happens first and the vascular changes are secondary to that. And we don't know. It's a sort of chicken or egg thing. This is the fellow eye of the same patient. So again, the foveal contour, often in sickle patient, it's splayed, so it's much wider and a bit shallower. This patient's not so bad. So the nasal retina is largely intact. This is, we mentioned right at the beginning that in the outer nuclear layer, the photoreceptor nuclei, there are two bands. The nuclei, there's a little line, you can just see a little faint line there. So the nuclei are actually outside of that, and this is Henle's layer. So these little dentate changes, these little white opacifications, is very much just orientation. If you repeat the scan, the patient looks slightly off center, they'll disappear. So it's just based on light reflectance. It's an artifact essentially of Henle's layer. So we now know that the nomenclature changes, and if anyone's seen pictures of high resolution OCT, which is the next technology which will come through in the next 5 years or so. It can break down 5 layers in the retinal pigment epithelium. Well, the reports say there's 28 layers on a high-res OCT, so we're going to have to learn all our terminology again when I do this talk again in 5 years' time. So if you look at the peripheral retina, I'm sort of going off on a tangent. When we look at the peripheral retina, very, very similar temporal loss. And when we look at the on-FAS image and the retinal thickness heat map, bit of epiretinal membrane there, but this patchy change, which is absolutely classic of sickle retinopathy and predominantly seen in SS patients rather than SC. And on an OCTA, the foveal avascular zone is enlarged. A normal avascular zone is 350 to 500 microns. Most of our sickle patients have got an enlargement of the foveal avascular zone and really an ischemic change at the retina. Right, better speed up a bit. Right, this change, very, very obvious again. Again, it's the same sort of thing. The retina can only decompensate in certain ways. Blood vessels get damaged. They can balloon up as aneurysms. They can occlude or they leak. So leak causes edema in the middle and exudate around it. So exudate is just lipoprotein. It's a big molecule. Big molecules travel furthest in the retina, and it just tells you the edge of edema. So we can see that obvious abnormality arises off an arterial. So it's a retinal arterial macroaneurysm. And a macroaneurysm is often an indicator of hypertension. So it's a feature of hypertensive retinopathy. So we look elsewhere again. We have irregularities in the arterial caliber. It's not smooth. There is a little bit of narrowing. I won't stress that any further. And if we look at the OCT, heavy exudate, and that's the macro in there. Remembering an OCT scan is artificially elongated in the vertical plane. So you can put them on a one-to-one and they would look much more circular. So you can manipulate the images depending on, but we artificially stretch out the architecture just so we can pick up the layers more effectively. So they leak, and they leak in every layer. So there's intraretinal fluid, subretinal fluid, exudate, so every feature, and essentially, and eventually they bleed. Now, the conventional wisdom, if they bleed, we don't need to do anything about because it completely deflates. That blood will scar the macroaneurysm. But if we see it like this, we will end up lasering this. So I saw this patient just last week, actually, and I zapped, did lots of laser treatment on that. And when I see the patient back in a couple of months' time, that should have constricted and shrunken on itself, and the exudate will take 6 to 9 months to clear. So it's a slow process. If we look at this eye, there's very anomalous circulation. So some similarities with sickle in the fact that they're very peripheral changes, but here there's ghost vessels. And look on this case, there's a sort of termination and there's no blood vessels beyond there. There are little hemorrhages. There's a very odd pattern here, but look at the disc and look at the fovea. It's very dragged. Now, normally you'd expect the fovea about at the lower pole of the disc about 2. So you'd expect the fovea to be there, and it's ectopic. So that gives us a clue what's going on. This is the fellow eye. The disc is very dragged. The periphery looks very odd. There's a little ridge there. There's no blood vessels beyond it. It's an abrupt termination. This is retinopathy of prematurity. And we're going to start seeing more and more of this as well. So again, it's in preterm infants, that final vascularization, or as we said, vasculogenesis, is orchestrated by oxygen tension levels and various genes. And if that environment changes, the blood vessel development goes awry. So it's these are neonates who have been born prematurely, sometimes on supplementary oxygen, but really relates to low birth weight and just early premature birth. And again, the OCT sign is blunting of the foveal depression, which we see quite commonly. But again, it just is a learning point. And normally on scans, you'll see the edge of the disc, and you can sort of just see where it's happening. It looks much more stretched out. And same with the other eye. The fovea is blunt. The disc is much further away than you expect. And these patients, and now the sort of newer recommendation with ROP is they need annual lifelong review because the rate of long-term, these patients are often myopic and they get very anomalous vitreous as well. So again, vitreoretinopathy um, is the term. An anomalous vitreous is seen in ROP patients, and this, as neonatal care has improved over the last 2 to 3 decades, these premature babies are now becoming adults, and we'll start seeing more and more of them because more and more have survived. And the sort of current advice, which changed a couple of years ago, is that they need annual review in a medical retina clinic because they're at relatively high risk of developing retinal detachment. And there's another condition which looks almost identical, FEVR. It's called a phenocopy. The same genes are implicated in vascular genesis, and those genes are misregulated in ROP. So again, very abnormal vasculature, peripheral exudative detachments. And if you look at the vascular branching pattern, this patient's had a CSR, unfortunately, in his other eye. And the fovea is very, very ectopic in this eye. So again, little clues. Again, the story is important. This patient has got something which looks really like everything else we've shown. Hemorrhages, cotton spots, little irregularities in the microvasculature, and some macular edema. So this patient had radiation retinopathy. It's relatively rare, but you'll see it in practice. And the thing is, and the reason why you're more likely to pick it up in practice than us in clinic is it typically kicks in 2 to 5 years after the radiation has been undertaken. So if there's a past history, medical history of cancer, or whether there's been localized, so it doesn't just happen in localized eye disease where there's been plaque brachytherapy, or retinal disease, which has had radiotherapy, will be tuned into those. These are patients who have had head and neck cancers and get external radiation therapy. And then, as you said, sort of 3 to 5 years later is the sort of peak incidence. And there's a whole host of changes. And the changes initially are really identical to diabetes, perhaps a little more widespread. And if it gets involved in the macula, they get macular edema. And then on a fluorescein angiogram, the changes are much more widespread because radiation is very harmful to blood vessels. That's why it works for tumors. It shrinks the blood vessel supply, and it damages the blood vessels in the eye as well. And this is an example of someone, a poor chap who had a nasopharyngeal, so it was deep inside. The only way they could get to the tumor is by irradiating through his eye, and he just completely lost all his blood supply. So huge neovascular complex and rubeosis. They end up losing the eye and his orbital content. I've only got a couple of cases left. Are we happy me continuing, or we can call it a day there?
I think people are still listening, so
Okay.
perhaps carry on.
Okay.
There was a
Yeah.
question about how you'd get an OCT scan on a newborn baby.
You wouldn't. That's by clinical examination. So that was an adult. So the story here is we wouldn't do it in babies if there are handheld OCTs available, so they can be done. But this is sort of just to reiterate some more recent guidance which has been issued worldwide over the last couple of years, where these prem babies are all now ex-prem babies, adults now. So you will see them as myopes with funny looking foveas, because survival for premature infants in the last 3 decades has really risen quite significantly. So these babies survive and end up having actually quite a lot of visual problems. So that's an adult, which was a prem baby. So you'll be seeing these patients in practice, and then you have to ask that question: were you a premature baby? Another question to ask in that long list of change.
Another question on that front then. So if we do see a case where we're seeing these sort of fundus changes, and it turns out the patient is a premature baby, sort of still a child, but a premature baby was a premature baby, are we recommended to refer those in?
Yeah, that's the current guidance actually, that they should be monitored lifelong.
Yeah.
So it seems to be there's an incidence or increasing incidence beyond the age of 20. So, you know, most of these kids will get discharged by the pediatric services, but certainly there's been a big push in, say, the international meetings that actually late registry studies and monitoring suggest people do end up running into difficulties. So there's sort of a surveillance thing. We'll probably end up doing Optos monitoring, I guess, eventually, but we're seeing more and more of these. Okay,
Yeah.
so I'll carry on. So again, the rule here is deep dark blot hemorrhages suggest ischemia. So, and the pattern of change. We've said diabetes is mainly a posterior pole disease. So the general rule is most diabetes is within 6 disc diameters of the optic nerve head. So most diabetic change in most people. Of course, you get anterior change as well. But in this patient, it's the inverse of that. Most of the hemorrhage is very peripheral. There's very few changes posteriorly. There's a few other changes in the retinal vascular caliber, but the predominant sign is deep hemorrhages. So deep dark hemorrhages in the periphery. The OCT scan shows very little in these cases. It's ocular ischemic syndrome. So again, this is not uncommon in actual fact, and we suspect this more and more in patients with very asymmetric diabetic retinopathy. It's supposed to accelerate changes in one eye, as you can imagine if you've got a slow flow. So when we do fluorescein angiograms on these, the filling is really, really quite slow. So this retina is really on survival. But these patients get anterior chamber flare and cells, sometimes rubeosis, but neovascularization of the disc. When they tip the balance, they get either rubeosis, neovascularization disc, macular edema, and we do PRPs early in these cases. And the key sort of slit lamp change is while you're, and this is both the vein occlusions and arterial occlusion off ocular ischemic syndrome, is when you're looking through, say, a biomicroscopy lens, Volk lens, and you're looking at the optic nerve head, just press on the eye with the other finger. The arteries are just collapsible. You put minimal pressure and the arterial supply just shuts down. So it's an important sign to pick up because these patients stroke out. This is intimately entwined with carotid insufficiency. When we see this finding, we do a carotid Doppler. The recommendations are anticoagulation to a certain point, but if the occlusion is beyond 80%, no, 70%, then they get referred to vascular surgeons for assessments and consideration of a carotid endarterectomy. So subtle changes can save people's lives or make a big change because these patients are at risk of stroke, because obviously if you get an embolization to the eye, most central retinal artery occlusion has some sort of coexisting ocular ischemic syndrome as well, because there's invariably carotid stenosis. So it's a really important clinical sign. If there's peripheral blot hemorrhages, think about ocular ischemia. And then what we would do is we would end up occasionally doing an angiogram, but the first step would always be a carotid Doppler study. So not really much to see on the OCT scan, but you get the occasional hemorrhage. So here, hemorrhage is blot hemorrhage, as you can see, just disrupts slightly the retinal cells. Okay, I've not gone so far over. I was nearly up. So in summary, there's a huge, broad variety. Obviously, the first retinal vascular disease is diabetes, but we did a separate session on diabetes. Vision loss from any of these conditions is really either macular ischemia or macular edema, or the secondary complications, neovascularization or exudate deposition. And you refer according to speed of it. If something comes on abruptly with acute and profound loss of vision, they need to go to eye casualty. But if something is chronic, there's a slow progressive change or the vision isn't impacted, then they can just be referred. And most of these conditions we can stabilize. So it is worth sending patients, even if they've been not treated. We get patients for tertiary opinions all the time. We treated someone just a couple of weeks ago who'd been watched elsewhere for 15 years with juxtafoveal telangiectasia, but had been mislabeled as something and tried with anti-VEGF. If you have to get the correct diagnosis to get the correct treatment, So if someone's told they've got a vein occlusion when it's juxtafoveal telangiectasia, then anti-VEGF doesn't work because it's a chronic malformation. It's not a VEGF-driven disorder. So laser works much better. So accurate diagnosis is key. So, send the patients in. Right, I'll stop there. So any questions?
Thank you. I'm just going to open it up to the floor. Is there any questions? While we're waiting on that, there's just a couple of people. I do need your GOC numbers. So if you wouldn't mind adding your GOC number to your name or typing it in the chat for me, and I can make sure you get your points.
Can I ask, the single point of access? So if you're getting these like branch vein occlusions and stuff like that, should they not go through the single point of access? Should they be going to direct straight away?
No, through the single point of access.
So, because he was saying some of them were like really urgent, so still the single point of access would be very urgent.
Yeah,
I just want to check.
No, so I'd say for an arterial occlusion, they should go straight to eye casualty. If you've got someone with a profound vein, remember central vein occlusions with profound loss of vision at baseline is quite uncommon. Most vein occlusions will have at presentation something between 612 and 624. It's really with chronicity that the vision starts deteriorating. So usually by 4 to 6 weeks, the vision starts going down. But 2/3 of patients will be absolutely fine and will just spontaneously improve. It is a subset. So for vein occlusions where the vision is still good, single points of access. So it's anyone with a sudden, profound, it's the arterial occlusions. They're the ones we really want to see because they're a stroke risk. So anyone with an acute arterial occlusion, if there's nothing we do from the eye perspective, we pretty much send them to the stroke team because remember the eye is just an externalized portion of the brain. The brain is supplied by the internal carotid artery. The first branch of the internal carotid is the ophthalmic artery. The second branch is the anterior cerebral. There is no difference between a retinal artery occlusion and a stroke. It's the same thing. It's the same disease, same condition. So we treat them the same. We send them to the stroke team for a workup because they
that should go straight to rapid.
Get them. Yeah, I just phoned the rapid access clinic because we'll try and hotfoot them straight to the stroke team. We'll have a quick look, confirm the diagnosis, and send them to the stroke team. If it's an embolic or a thromboembolic stroke or thromboembolic artery occlusion.
Yeah, yeah. So the arteries we treat as an emergency, but
Yeah.
the vein would come.
The vein would go through the points of access. Yeah.
Okay, thanks.
Unless the vision is if it's terrible, you can argue that it still goes to the single points of access because a vein occlusion with terrible vision is never going to get any better. You can inject them, but there's a ceiling on how much gain. So the sweet spot is someone whose vision is compromised with macular edema, and you get a sort of 4 to 6 week window where you can get on top of those patients. But always the best, if it's your own eye, that's guidance. That's still not necessarily best practice. Best, if it happened to my eye, I'd want a treatment within a couple of weeks, really. I'd give it a few days just to see whether there's any chance of spontaneous improvement. But if it's going downhill, I'd want to be treated. And more often than not, at St. Thomas's, we tend to walk patients straight into one of the medical retina clinics and just get them injected. But that's not a recommendation to send everything to St. Thomas's. Send them to your local hospital. They're inundated otherwise.
Thank you. Thanks for answering the question.
Thank you. Was there any other questions?
Oh, Davina, I've got one, please.
Yeah, Irene, go for it.
Just, if a patient just really mild, if they've just got blood vessel tortuosity, but nothing else. And I remember someone telling me that if the big blood vessels, as well as the small blood vessels around the macula, are very wavy, then it's more likely to be congenital. But if it's only the small blood vessels around the macula that are very tortuous, and that's more likely to be hypertension. Is that true?
It depends on whether you've got evidence of pictures before the symmetry and whether you talk about the arteries of the veins. So if it's the veins and it's very asymmetric, look very closely in the periphery, it's more likely to be But idiopathic retinal vascular tortuosity is an entity, but it's relatively uncommon. So yeah, if someone's got particularly tortuous vascular, I mean, it's very, very curly. There's all sorts of studies on this and trying to define some sort of numerical retinal vascular tortuosity index. Very difficult to do because no one can agree on what retinal vascular tortuosity is. But more often than not, it's the indicator of, you sort of make an assumption. But if the visual acuity is excellent, the patient's noticed nothing and there's no macular edema or hemorrhage, then you can assume, and the blood pressure is normal, then you can assume it's idiopathic. But generally, it's retinal arteries and veins. If it's just the veins, then suspect some sort of incipient vein occlusion and monitor them closely, particularly if it's asymmetric between the two eyes. But if it's a genetic, hereditary, or if it's part of ocular vasculogenesis and malformation of the blood vessels, you tend to get symmetry.
Okay.
But it's a general picture, yeah. So if the eyes are functioning well, then we're not so alarmed. And there's no other sign. Chronic decompensation always causes either hemorrhage or exudates or cotton wool spots if there's some sort of compromise. But if there's nothing, vision's good, OCT scans normal, there's nothing much in the periphery and it's symmetric, then I probably wouldn't worry so much. And then, then in practice, I'd just if you're confident, then I'd just repeat imaging in 4 months if it's the first diagnosis, and if there's no change, then a vascular workup by the GP, just to be certain there's nothing else going on.
Okay, lovely. Thank you.
Thank you. Right. If there's no more questions, I'm going to just stop the recording.